Hi everyone, welcome back to the TinyDocs podcast series, Pediatric Interview Edition, your source for the clinical thinking station of pediatric training interview in the UK, brought to you by the British Sudanese Association of Pediatric and Child Health, or BSAPCH in short. I'm your host Isra Ibrahim, and joining us today both of our presenter Guiria Ibrahim and Hanan Aliab to present real life demonstration case of clinical thinking station. So, without further ado, let's dive into our episode.
You were in the ER, you are registrar in the emergency department, and a 7-year-old boy brought you with his family running, rushing to you. The child is came from was drowning, in case of drowning, full immersion, and his clothes were wet. He cannot breathe, and he is really floppy in their hands. When you examine him, you find that there is no, you couldn't find pulse and not breathing.
So most likely dealing with a case of drowning who is unresponsive and there is no pulse. So actually this is a critical and emergency situation. I have to activate the emergency response system immediately, and I will involve my senior, and I will delegate the role to my team, and I will push him immediately to the resource room. As there is, he's not responsive and there is no pulse and no sign of life, I have to start for him and immediately basic life support, and I have to connect him to the monitor immediately and apply oxygen by 100% oxygen by non-rebreathing mask, and I will be careful in immobilizing the neck if there is any suspicion or evidence of cervical spine injury. So I will start the normal, the sequence of basic life support by chest compression, and I will inform the anesthesia team immediately to put an endotracheal tube and to intubate and ventilate immediately. Meanwhile, I continue to approach him by an ABCD approach. So after securing the airway and immobilizing the cervical spine, I will move to the breathing. Is this child pick up and there is normal breathing or no? I have to listen to his chest bilaterally and to see if there is any response or any chest rise. Then I will move to the circulation. I have to check up there is no pulse. I have to secure an IV, large bore IV cannula. Or if I felt I have to put an interosseous immediately, I will start to expand his circulation by providing him a bolus of IV fluid, crystalloid IV fluid, and I will put in my mind regarding his temperature. May I have to use and warm saline. Then I have to withdraw blood for full blood count, blood gas, lactate, inflammatory markers, and blood culture, use an ease, coagulation profile, and blood group and safe and cross matching. Then I will move to the D. If this child most likely he is not responsive, so I will assess his Glasgow Coma scale from the beginning. I will examine his pupils bilateral, and I will measure his blood glucose. If he is hypoglycemic, I have to give him a bolus of dextrose. Then I will move to the E and to expose this child immediately, and I have to remove his clothes, as this is may compromise hypothermia more, and we'll measure his core temperature, and I have to wrap him with I will take the measure to prevent the hypothermia. I have to cover him by a heated blanket or by turning on the heat system. Then I will continue to monitor his ABCD again and to re-evaluate according to the fluid. I have to titrate the fluid to regain normal blood pressure and normal cavity refill time, and I have to put and urinary catheter to measure his input and output. And I will continue to give more fluid if needed, and if more than 2 bolus is still this child shock, I have to consider to give him an inotrop, but this is after discussion with my consultant, and I have also to involve the PICU team. Then I have to take also, I ask one of my team to bring the protocol of drowning, and I will ask also for an chest x-ray. So it is according to the situation. If this patient is still hypothermic, I have to take the measures to reduce this hypothermia. Like I will, in addition to giving and warm IV fluid, I have also to consider and gastric lavage by warm saline at 39, or urinary also bladder lavage, and also we will consider, I have also to involve the surgery team to put a peritoneal catheter for peritoneal lavage. Then I have to update the family about the situation step by step, and I have to take an history from the event in details, when this drowning happened, for how long he stay in the water, and if there is any basic life support given at the scene or the not, or if given how many he regained his spontaneous breathing. And I will ask also about the nature of the water. Is it dirty, or so maybe is it contaminated water? So I have me to consider to giving a broad spectrum antibiotic, or according to the local protocol. So we have also to monitor this child, his rhythm, and his heart rate, and his circulation also. I think definitely this child need an PICU admission. So I will admit him to the PICU for further management. And after that, I will do a debriefing session to our team. Thank you.
At the end of today's episode, me and Bisab CH would like to extend our thanks to our presenter, Guiria Ibrahim and Hanan Aliab, for sharing their thoughts with us. We hope that this episode has provided some sort of guidance for the clinical thinking stations. Remember, our journey does not end here. Be sure to check out the rest of our media outlet, our YouTube channel, our website, and the rest of our podcast. Remember also, your feedback is valuable. Please reach out and share your thoughts, questions, or suggestions. Together, we can improve and provide content that meets your need. Thank you for tuning in, and until next time, stay curious and keep learning.